Hello everybody. Today we are going to discuss about Sepsis Guidelines 2026. So they have in the recent guideline they have introduced certain terminologies like definite sepsis, probable sepsis, possible sepsis and unlikely sepsis. Definite sepsis means sepsis confirmed based on the history, clinical examination and diagnostic testing where the possibility of the alternative diagnosis is very unlikely. Probable sepsis is suspicion of there is definitely high suspicion for sepsis, but there is slight possibility of the alternative diagnosis as well. Possible sepsis is moderate suspicion for sepsis, and unlikely sepsis means there is very low suspicion for the sepsis. Now let's talk about the screening. How to screen? So there are several scoring systems which are available for the sepsis like News, News2, News, and SIRS over QSOFA as a single tool for to screen for sepsis. About biomarkers, sepsis is the clinical diagnosis and should not be ruled in or ruled out on the basis of single biomarker or diagnostic test. And there is insufficient evidence to make recommendation regarding the use of novel rapid host response diagnostic. That means we should not rely on any specific biomarker to diagnose sepsis. About the blood culture, if we are suspecting possible, probable, or definitive sepsis, then it is recommended to collect the blood culture as soon as possible, ideally before administration of the antimicrobial, so that we can catch the organism better and treat accordingly. About the blood lactate level in adult with the possible, probable, and definitive sepsis, we suggest measuring blood lactate levels. Yeah, means if we have the if lactate, if the lactate levels are on the increasing trend, then we can talk about the worsening of the we can think about the worsening of the septic shock, and we can take the measures accordingly. About the fluid resuscitation, sepsis, and septic shock, these are the medical emergencies. So the treatment and the resuscitation should begin as soon as possible. So as far as fluid resuscitation is concerned, so we suggest giving at least 3 ml, 30 ml per kg of IV crystalloid over first 3 hours. So again, this 30 ml per kg is not any magical figure. So we should individualize this fluid resuscitation targets. That means, so it's a consideration should be given to the patient characteristic and the context when selecting the initial fluid resuscitation. That means if the patient is having already CKD or already is having IHD, then we cannot keep on giving fluid. Or while giving fluid means if there is a time of if while giving fluid resuscitation, if you have started like 30 ml per kg, that means suppose the patient's weight is 60 kg. So 30 ml per kg means we should give 1800 ml of the fluid. But while giving fluid, we should always check for the fluid responsiveness. That means we have given the fluid, but whether the patient is responding to that our fluid therapy or not. So how to check it? So we can check it by various methods like IVC, passive leg raising, LVOT, BTI. And if the patient is responding to our fluid resuscitation, then only think about giving more fluids. Otherwise, stop there only because this fluid will cause more harm than the benefit. Uh, so about the weight-based fluid volume, it should be calculated based on actual weight or by adjusted or ideal body weight if the patient weight is more than 30 kg. So regarding the time of vasopressor initiation relative to the fluid resuscitation, means what we should do, when we should start noradrenaline? Should we start along with the fluid? Should we start after finishing fluid resuscitation? What we are supposed to do? So these guidelines recommended if the adult is diagnosed with sepsis induced hypotension, then we need to initiate fluid resuscitation first and then followed by vasopressor. But if our patient is having unstable shock, that means if the patient is having reduced blood pressure, mottle skin, ashen appearance, cyanosis, decreased oxygen saturation, tachycardia, altered mental status, then do not wait for finishing fluid resuscitation. We need to give vasopressor simultaneously. About the route of vasopressor administration. So, as we all know, vasopressors can be administered by peripheral route or central route. Ideal way is central route. So, while starting a noradrenaline, if in case of like patient is very hypotensive, then do not wait for the central line and all. Just start the vasopressor with the peripheral access, because perfusion is important here. Now about the mean arterial target. For adult with the septic shock, we should always maintain the map of 65 mmHg, or we can maintain it within the range of 60 to 65. So that's the idea. About the admission to intensive care unit. So for sure, if you are suspecting sepsis or if the patient is going into septic shock, without wasting time, we should admit the patient into ICU for intensive care treatment and monitoring. So, regarding infection, for adult with possible, probable, and definitive sepsis, we recommended administered antibiotic as soon as possible. That is within 1 hour of the recognition. So, the catch point here is, so many times we are in the diagnostic dilemma, whether it is septic shock or other mixed shock. So, whether we should go for the broad spectrum antibiotic or not. So, to solve this, to answer this question, if we are sure about this shock is septic only or none other shock is possible, then yes, we should give the broad spectrum antibiotic as soon as possible. That means within 1 hour, because our choice of antibiotic will decide the fate of that patient. But yes, if you are not sure, or if the patient is not hypotensive, or if the patient is only have sepsis, and we have the possibility of other diagnosis also, then take a time. Then take a time of 3 hours, complete your examination, rule out other possibilities. But in that case also, these guidelines are recommending to administer antibiotic within 3 hours. So this is the pictorial representation when we should administer antibiotic. So the sepsis is definite, probable, possible, and if shock is present, then do not waste time. Administer antibiotic as soon as possible. That means maximum you can take 1 hour. But if the shock is absent and you have diagnostic dilemma, then complete your examination, and you can delay that administration of the antibiotic thing for 3 hours. But don't wait for longer than 3 hours. Now, the timing of antibiotic initiation en route to hospital. Suppose you are working in some periphery hospital where you don't have the facility, and if you are thinking now the patient is sinking, patient might go into the septic shock, and you want to shift that patient to higher center, then do not wait. Then do not wait. Administered anti and if you know that I cannot reach the hospital for means yeah, definitely I cannot reach the hospital within 1 hour, then you can administer antibiotic in between the way, or in ambulance, or in flight, or wherever you are. So do not delay your this decision of administering antibiotic. If you are working in PHC and facilities are not available, and if you are planning to shift that patient to higher center, and if you already know that I cannot reach to the higher center within 1 hour, then do not waste your time, because again I am repeating, the decision of antibiotic is the most crucial decision, and it will be life saving for the patient. Now about the biomarkers guided initiation of antibiotics. Should we wait for the biomarker for antimicrobial initiation? Answer is no. We should, if your clinical examination is saying it's possible, probable, and definitive septic shock, then you can start antibiotic just on the basis of the clinical evaluation without waiting for any biomarker. Now about the source control. See, whatever you will do, you will give fluids, you will give antibiotic, but if you do not manage your source, then it is not going to help at all. So, according to these guidelines, the source control ideally should be done within 6 hours. But yeah, ideally it should be done as soon as possible. If you know the source, if you know this is the so like the source of infection is abdomen, source of infection is lower limb, source of infection is chest, yes, you have to act immediately to control the source of infection, and it should happen as soon as possible. The answer of this question is source should be controlled as soon as possible, and according to the guideline within 6 hours you should act. Means within 6 hours your source of sepsis should be under control. Now about starting empirical multi-drug resistance coverage for adult with septic shock at high risk of infection with specific MDR pathogen. We suggest using empirical antimicrobial therapy with the coverage for MDR. But yes, we should consider I want to start antibiotic and I want to give MDR coverage. So I cannot give MDR coverage for each and every patient. So to whom should I start with MDR coverage? So MDR coverage should be given to those patients who are at risk of MDR related pathogen like previous infection with the MDR pathogen, prolonged use of broad spectrum antibiotic, prolonged hospitalization, and with high prevalence of MDR pathogen. So only to those patients we can give good MDR coverage. Otherwise, we can we can like individualize. Now, what about empirical antibiotic antifungal coverage? Again, for empirical antibiotic antifungal coverage, consider about the risk factor like immunosuppression condition, prolonged use of antibiotic, prolonged hospitalization, intra-abdominal source of infection. If these factors are present, then only consider giving empirical antifungal coverage. Otherwise, there is no need. We cannot keep on adding antifungal for each and every patient. About empirical and anaerobic coverage. So about empirical anaerobic coverage, the answer is same. We should always look for the risk factors like intra-abdominal, deep-seated, gynecological, obstetrical source of infection, necrotizing soft tissue infection, head neck infection, CNS abscess, and empyema. If these risk factors are there, then only empirical anaerobic coverage will work. Otherwise, there is no need of giving left and right anaerobic coverage for each and every infection because the whatever antibiotic we are starting, like if the patient is going into septic shock, yeah, then obviously broad spectrum antibiotic like piptaz meropenem will add, which already have anaerobic coverage. So let's read this recommendation. For adult with septic shock without risk for anaerobic coverage, we suggest using empirical antibiotic regimen without anaerobic coverage. So if there is no risk of anaerobic coverage, no need of giving unnecessarily anaerobic coverage. But yes, if there is a risk factor, we should go for additional anaerobic coverage. Whatever antibiotic we have started, we should give anaerobic coverage to that. Now, what microbiological surveillance? There is insufficient evidence to make recommendation regarding the use of departmental microbiological surveillance sample of upper respiratory tract to guide empirical antimicrobial therapy. About pathogen-specific rapid diagnostic test. For adult with septic shock, we suggest using pathogen-specific rapid diagnostic test on case-by-case basis in selected patient based on clinical feature, local pathogen, resistance pattern, seasonability, availability of the test, and antibiotic stewardship guidance. About Candida fungal biomarker. For adult with septic shock, we should not like what means before releasing these guidelines, what we used to practice is whenever the patient is in septic shock, we used to send the candida biomarkers like BDG. If that BDG is positive, we used to start with the antifungal because the sensitivity of the BDG is around 95. The specificity is very less. So if the BDG is positive, specificity is around 70%. So if the BDG is positive, yes, there is a chances of fungal infection, but always we should keep in mind BDG is many times false positive. Like if the patient is on dialysis, if the patient is already taking piptas, some antibiotic, if the patient is already receiving albumin, then the PDG will come as positive by default. So, but if the BDG is negative, then definitely we can rule out antifungal infection. So, according to these guidelines, so what they are suggesting is we should not rely on any marker to start antifungal. Like if the patient is high risk of fungal infection, then only give good antifungal coverage. Now, what does this mean? This means if the patient is immunosuppressed, if the patient has already received prolonged antibiotic, prolonged hospitalization, and if the source of infection is intra-abdomen, then only start with antifungal, otherwise no need. Now about prolonged infusion of beta-lactam antibiotic. The prolonged infusion of beta-lactam for maintenance over bolus dose is recommended. Now about therapeutic drug monitoring, we suggest using antimicrobial therapeutic drug monitoring on case-by-case basis in selected patient based on clinical feature, local pathogen, resistance pattern, drug class, and availability of the TDM. But yeah, it's really difficult to practice, I would say. Now about antimicrobial de-escalation. So clinicians should continuously reevaluate patients, search for alternative diagnosis, discontinue empirical antimicrobial therapy if alternate cause of the illness is demonstrated or strongly suspected in patients with this suspected sepsis, septic shock, but unconfirmed infection. So for adult with septic shock, it is recommended to de-escalation. It is recommended to consider de-escalation of antimicrobial therapy over no de-escalation when confirmed microbiological diagnosis and susceptibility profile is available. Means we should consider means if you have definitive culture report and if you can feel that the antibiotic is this particular organism is sensitive to narrow spectrum antibiotic also or lower antibiotic, then then definitely we can think about the de-escalation. So de-escalation involves discontinuing unnecessarily antimicrobial therapy or narrowing the spectrum of antimicrobial agent whenever appropriate. So obviously, yeah, so it is recommended to de-escalate antibiotic over no de-escalation whenever the situation is appropriate. Now, should we consider biomarker for discontinuing antifungal therapy? So let's see what these guidelines are saying. So these guidelines are against using candida fungal biomarker to guide discontinuation of empirical antifungal therapy. So this is something very new because previously on the basis of BDG, we used to de-escalate antifungal therapy. Like I said before also, whatever we used to practice is when the BDG is negative, we used to stop the antifungal. But according to this guideline, BDG has absolutely no role, even if the BDG is positive, but even if the BDG is negative, but if your clinical suspicion is strong, yes, we should continue giving antifungal. Now about the duration of antimicrobial therapy. For adult with the initial diagnosis of septic shock, and adequate source control, we suggest using short over longer duration of antimicrobial therapy. So recently one trial has also published, which is balanced trial, which was also in the favor of practicing 7-day course of antimicrobial over 14 days. Now about the biomarker guidance for antibiotic discontinuation. For adult with initial diagnosis of septic shock, and adequate source control where optimal duration of therapy is unclear, we suggest using PCT and clinical evaluation to decide when to discontinue antimicrobial therapy over clinical evaluation alone. So whenever the patient is admitted with septic shock, we are continuously evaluating that patient. We are giving the antibiotic for some fixed duration. Then we are thinking about the discontinuation of the antibiotic. So when is the time to discontinue antibiotic? So the decision of the discontinuing antibiotic should be the combined decision based on clinical evaluation as well as biomarkers like PCT. Now what we should do about the selective decontamination of the digestive. So yes, these guidelines are in the favor of using selective decontamination of the digestive tract when mechanically ventilated adult with septic shock with the low prevalence of antimicrobial resistance. So this is the schematic representation of treating patient when patient is diagnosed with septic shock. So what we should do when the patient is admitted with sepsis, with hypotension and elevated lactate. So first we should monitor it very carefully. Like we should keep eye on blood pressure, heart rate, respiratory rate, level of consciousness. Within 1 hour, check serum lactate, capillary refill time. Within 1 hour, if you are sure about the septic, where this we are, I'm dealing with the septic shock, and it's none other than the septic shock. Administered broad spectrum antibiotic as soon as possible. Complete your fluid resuscitation, that is 30 ml per kg within 3 hours. Again, the rate of the fluid resuscitation is individualized, also depend upon the fluid responsiveness. About the diffusion of vasoactive agent, so if it is only sepsis induced hypotension, yes, complete your fluid resuscitation and start vasopressor. But if it is unstable septic shock, like I have mentioned before, if the patient is having cyanosis, mortal skin, along with your fluid resuscitation, give vasopressor also, and try to maintain the map of 65 mmHg or at least in the range of 60 to 65. So if hypotension persists beyond that, then yeah, we should check for the fluid responsiveness, use the dynamic measures for assessing the fluid responsiveness. We should always keep eye on the lactate, capillary refill time, give additional fluid, prefer balanced crystalloid solution, add hydro. Yeah, if your NORAD requirement is keep on increasing, then add hydrocort in the septic dose like 50 mg QID. Yeah, and if your patient is not responding to norepinephrine, you can think about adding second inotropic, second vasopressor agent like vasopressin. And if the patient is having sepsis induced cardiac dysfunction, then give epinephrine or dobutamine. Epinephrine is preferred over dobutamine. About blood pressure monitoring, so use either invasive or non-invasive blood pressure monitoring. Invasive blood pressure monitoring is advised in patients with shock who require immediate, intermediate, or a high dose vasopressor, escalation of the dose of vasopressor, multiple vasopressor, or receiving frequent blood sampling, or those who have non-invasive blood pressure measurement, which are inconsistent on repeated who have which are inconsistent on repeated assessment. So there is a debate whether we should go for Artline or not. But yes, my personal experience, Artline is very useful while monitoring BP and collecting blood sample also. So it's better if you will secure the Artline if you are dealing with the septic shock or any hypotensive patient. So about the fluid therapy, it is recommended using crystalloid as a first line choice for the resuscitation. We can also go for the balanced crystalloid solution like over 0.9% saline. So for patient with the sepsis, traumatic brain injury, yeah, you can go with the 0.9% saline. So the simple answer of this question, which fluid we should use, those the simple answer is we can go for any balanced crystalloid solution for fluid, for starting fluid. So for adult with septic shock, it is suggested using crystalloid alone over crystalloid with supplemental albumin. So as such, there is no role of albumin in septic shock, but yes, we can use albumin if we are dealing with the cirrhotic patient, or in case of HRS, or in case of like there are few conditions in which we can use albumin, like yeah, patient is already having CLD, HRS, SBP. If we know about if we are sure about this diagnosis, we can start with the albumin. Or for fluid resuscitation, there is no role of albumin. Absolutely. About liberal and the conservative fluid strategy. So for adult with septic shock who have already received fluid resuscitation, we suggest using either liberal or restrictive fluid strategy based on the individual patient. So whether we should go for the liberal or whether we should go for the conservative fluid strategy, again the answer is very individualized. There is no robust data, at least on the septic shock, whether we should go for whether we should follow a liberal strategy or conservative strategy. So the one thought is if the patient is highly unstable and if the patient is requiring resuscitation, then yeah, for first 48 hours you can go with the liberal fluid strategy. So as I mentioned before, while starting fluid resuscitation, you can follow 30 ml per kg. But yes, we have to follow precautions while giving 30 ml per kg of the fluid. We should check for the underlying comorbidities of the patient and also about the fluid responsiveness. So if you take care of this patient, yeah, and so I think whenever if you take care of these factors, then your fluid resuscitation will be good and it will help the patient. And while giving fluid, if your patient is going into it develops B line or if it is going into the fluid resuscitation, then that's the time to stop the fluid or follow your de-resuscitation strategy. Now, about the fluid resuscitation should be guided by the dynamic measures like passive leg raising test, stroke volume variation, pulse pressure, and pulse pressure variation. Now, about the cardiac monitoring device. So, there is insufficient to make recommendation on minimal invasive or non-invasive cardiac monitoring in addition to the usual care. Now about role of serial lactate. For patient with the sepsis and elevated lactate septic shock, we suggest using serial lactate measurement to guide resuscitation. So fluid resuscitation should be individualized after initial fluid and monitoring of the lactate decremental rather than continuing fluid until lactate normalization is achieved. About capillary refill time, while giving to guide resuscitation, we should use capillary refill time in addition to the other measures. About IV vasopressors, for adult with septic shock, it is recommended using norepinephrine as a first line vasopressor over dopamine, epinephrine, and serlipressine. For adult with septic shock, we suggest against using terlipressine. For adult with septic shock, we suggest using epinephrine as a first line agent over vasopressin and angiotensin 2. That means if the patient is having uh, like we suggest like norepinephrine should be always the first line of vasopressor over vasopressin or other vasopressors like angiotensin 2 or epinephrine. For patient with septic shock on escalating dose of norepinephrine, so if our so when to add vasopressin, so if our noradrenaline requirement is increasing, then only we should consider adding vasopressin. For adult with septic shock and inadequate MAP target, despite norepinephrine and vasopressin, we should consider adding epinephrine because we might deal with sepsis-induced cardiac dysfunction. So yes, in that case, we can add epinephrine instead of, means epinephrine is preferred than dobutamine, and there is very less evidence for use in that. So norepinephrine may be preferred in patients with tachyarrhythmias and significant sinus tachycardia, and epinephrine may be preferred in patients with bradyarrhythmia and significant sinus bradycardia. So about methylene blue, whether we should use methylene blue, there is absolutely no evidence for methylene blue. Now about adding inotropes. So for adult with septic and cardiac dysfunction with persistent hypoperfusion, despite adequate fluid status and arterial blood pressure, we suggest using inotropes over no inotrope. So for patient requiring vasopressor to maintain MAP at target, inotrope should be used in addition to the vasopressor. So like I mentioned before, Whenever we are dealing with hypotension, definitely we'll add vasopressor in the form of norepinephrine. If dose of the norepinephrine is increasing, we are adding vasopressor. But whenever there is if the BP is still not picking up, and if there is sepsis induced cardiac dysfunction, then it is recommended to take help of inotropic agent to like epinephrine. So, for adult with septic shock with persistent hypoperfusion and cardiac dysfunction, despite adequate fluid resuscitation, arterial blood pressure, we suggest adding dobutamine, norepinephrine, or using epinephrine alone. There is insufficient data to make recommendation for dobutamine or milrinone. So also there is no data for using glucosamine. Whether we should use midodrine, so there is very insufficient evidence on using midodrine. About using beta blockers, we should not use beta blocker for septic shock. There was one thought for using beta blocker for controlling heart rate, so that there is improvement in the diastolic function of the heart. But according to the recent guideline, there is no use of IV beta blocker to control heart. So about respiratory monitor. For adult with the sepsis, we suggest monitoring oxygenation by either pulse oximeter and the arterial blood gas in conjunction with physical examination. Arterial blood gas measurement is the gold standard for assessing oxygenation. Include other important information like pH, PCO2, lactate, bicarbonate. So SpO2 FR2 ratio by pulse oximetry may substitute for PF ratio, but less accurate in patient with shock and darker skin tone, and with oxygen saturation is less than 90% or more than 97%. So SF ratio is so we can go for either SF ratio or PF ratio. Now about oxygen target. How much oxygen target is acceptable? So there are variability in the range. So what oxygen target we should maintain, but it is recommended that approximately 90 to 93% of SpO2 or higher target of the SpO2 like more than 96% we can maintain. So in our practice, panelists target SpO2 between 90% to 96% for patient with sepsis and acute hypoxemic respiratory failure. Now about NIV support for sepsis and acute hypoxemic respiratory failure, it is recommended to use high flow nasal cannula over NIV. So it is recommended to this recommendation. So whether when we should go for the high flow nasal cannula. So if the PF ratio is less than 200 and SF ratio is less than 235, then it is suggested to start high flow nasal cannula. That means the patient is in respiratory failure, and high flow nasal cannula is preferred over NIV. So about awake proning. So in patient with sepsis and acute hypoxemic respiratory failure who are not intubated, we suggest trial of awake proning. It will really help in patient with the septic shock with respiratory. About invasive mechanical ventilation. For adult patient with sepsis and ARDS, it is recommended to follow lung protective strategy, that is low tidal volume over high tidal volume. For adult with sepsis associated hypoxemic respiratory failure without ARDS, then we can use tidal volume of 6 to 8 ml per kg of ideal body weight over lower tidal volume. So patients should be screened regularly for development of ARDS, and ARDS diagnosis is often missed or delayed. So it is recommended because this patient of the sepsis, whenever they are going into the respiratory failure, keep the possibility of ARDS always in your mind, and start the lung protective ventilation. Okay. So what is what is lung protective ventilation? Means we should keep the low tidal volume like 6 ml per kg of body weight. Plateau pressure should be less than 30. at least this much. And about PEEP, PEEP is always we should go for the optimum PEEP. There is no high PEEP or low PEEP, but according to this guideline, so if we are dealing with the moderate to severe ARDS, keep a will PEEP little high, but yes, we should always keep the PEEP according to the driving pressure. If we have kept certain PEEP and if your driving pressures are high, then there is absolutely no use of that PEEP. So the selection of the PEEP always should be always guided by driving pressures and other hemodynamic parameters. So while giving, uh, so if a patient is still hypoxic, go for the prone ventilation for more than for 12 hours. And like there are other criteria for prone ventilation, like your patient is hypoxic persistently, PF ratio is less than 150. Yes, definitely go for the prone position. If the patient is sepsis and moderate to severe ARDS, then go for the intermittent neuromuscular blocking bolus over continuous. Now about veno-venous ECMO, if the patient is again hypoxemic on prone position and despite giving all the measures for improvement of oxygenation, then go for veno-venous ECMO. About IV corticosteroid, we suggest using IV corticosteroid. About antipyretic, don't use antipyretic agent, don't go for the blanket antipyretic measures. So these guidelines are against use of antipyretic therapy, either pharmacological or surface cooling, for the purpose of improving clinical outcome. This does not apply to using antipyretic therapy for pain control, patient symptom control, and for patient with other indication for temperature control, like neurocritical care patient and patient after cardiac arrest. Vitamin C, no role again. IV immunoglobulins also has no role. Blood purification technique like use of polymyxin B, hemoperfusion, like Oxaris filter, again, no role, strongly no role. Vitamin D also no role. Stress ulcer prophylaxis. About stress ulcer prophylaxis, though give stress ulcer prophylaxis those who have risk for the GI bleeding. Like it is suggest using stress ulcer prophylaxis with PPI over not using stress ulcer prophylaxis who has risk of GI bleeding. Like if the patient is on the mechanical ventilation, yes, we should start with the stress ulcer prophylaxis. About probiotic, again, no role. About active fluid removal for adult with septic shock after acute resuscitation phase, we suggest active fluid removal like with the help of diuretic, ultrafiltration, and extracorporeal fluid removal. So factors to be considered when deciding to initiate active fluid removal include cardiorespiratory function, vasopressor dose, clinical course, peripheral edema, weight, and fluid balance. About the blood transfusion, we recommended using restrictive transfusion strategy over liberal strategy. About enteral, we should start with early, that is within 72 hours of initiation of, means for adult with septic shock, it is suggested early initiation of the enteral nutrition, that is within 72 hours. About insulin therapy, try to maintain the blood sugar level between 140 to 180. About renal replacement therapy, for adult patient with septic shock and ACAD with no definitive indication for renal replacement therapy, do not go for it. But yes, if there is a indication, go for renal replacement therapy like any modality, like means according to the hemodynamic, CRRT or SLATE, if it is indicated. So about SLATE, just to improve hemodynamics or just to deal with the acidosis, hypoperfusion, don't use bicarbonate. But if the patient is in septic shock, severe metabolic acidosis, and AKI, we suggest using sodium bicarbonate therapy. About venous thromboembolism prophylaxis, septic and septic shock, it is recommended using pharmacological venous thromboembolism prophylaxis unless contraindicated. So go for low molecular weight heparin over unfractionated weight heparin. Also, use pharmacological venous thromboembolism prophylaxis alone over pharmacological plus mechanical venous thromboembolism prophylaxis. So the take-home message for using to venous thromboembolism prophylaxis is go for low molecular weight heparin like this enoxaparin over unfractionated weight heparin, and we should always use pharmacological alone over or go for pharmacological alone over combination of pharmacological plus mechanical. So goals of care for adult with septic shock, clinician should discuss the prognosis with patient and family. For adult with septic shock, we suggest goal of care early, like within 72 hours over late, that is after 72 hours. Thanks a lot for patient listening, and I hope you all will implement this guideline into your practice. Thank you. Thanks a lot.